Okay, hello everyone. I'm going to be talking, this will be the first video, one of 4, on pain medications. And this also includes NSAIDs and the mild pain medications, but a lot of this lecture is going to be about opioids and how they help with an analgesic effect or calm people down. So basically, you can read here, a pain threshold is a physiological response of the nervous system, therefore similar in most people. Variations in sensitivity may be a result of genetics. It is controlled by the opioid receptor gene that we all have. Pain sensitivity is diminished when the receptors are present in abundance. When they're diminished, small things cause great pain, and they're saying we have a genetic predisposition to that. And then pain tolerance will vary from person to person, will depend on the patient's individual personality, environment, culture, ethnic background. Acute versus chronic. We know acute is sudden and usually subsides when treated. Example would be post-op pain, a bullet wound, something like that. Chronic is persistent and reoccurring, and we also know that that's going to last between 3 and 6 months. Much more difficult to treat because changes do occur in the nervous system with chronic pain, causing the patient to need increasing drug dosages. And look at all these sources. Incredible. We've got somatic, which originates from skeletal muscle, ligaments, and joints. We've got visceral, which originates from organs and smooth muscles. Superficial is just what it says. It's kind of, on top, originates in the skin, mucous membranes. Vascular always means blood. Originates from the vascular or perivascular tissues. Example of this would be like a migraine headache. Referred as when pain is experienced in an area unrelated to the injured site. An example would be gallbladder pain, cholecystitis, which we know is kind of high in the abdomen, but a lot of times it's referred to the back or the scapula area over your shoulder. It happens because visceral nerve fibers synapse at a level in the spinal cord close to fibers that supply specific substances to tissues in the body. Neuropathic is going to be along a nerve, results from injury or damage to a peripheral nerve fibers or damage in the central nervous system. Phantom is a very interesting type of pain. It occurs in the area of a body part that has been removed surgically or traumatically, characterized as burning, itching, tingling, or stabbing. It can also occur in attached limbs following spinal cord injury, meaning what they mean is the body part's not there with a lot of phantom limb pain, like from diabetics. And so you have an amputation from the knee down, but yet they can feel the foot. They say they can feel it. That's why they say it's phantom, almost like a ghost. Very interesting, but it's real. Cancer, acute or chronic. We know cancer as it grows, especially metastatic cancer and end stage. It's because it's so out of control with the growth. It puts pressures on nerves, organs, or tissues. May also cause hypoxia, blockage to an organ, pathologic fractures, muscle spasms. There also can be all kinds of effects from radiation, surgery, and chemotherapy. It can cause pain, depending on what they're getting. Psychogenic originates from psychologic factors in our brain, not physical conditions or disorders, but physiological sources must be ruled out. Can never just be ruled out. And then central pain occurs with tumors, trauma, inflammation of the brain, may accompany any condition that causes CNS damage, which is the brain. Central, we're talking about the brain, not the center of the body. For cancer, diabetes, stroke, multiple sclerosis, anything that's going to attack the central nervous system, we would call central pain. Okay, we talked a little bit about the gate theory already, but once again, I just want to give you a little history. It was proposed by Melzack and Wall, two scientists in 1965. They used the analogy of a gate to describe how impulses from damaged tissues are sensed in the brain. The tissue injury causes release of many substances in the blood: bradykinin, histamine, potassium, cells rupture, prostaglandins, and serotonin. So then the action potential is initiated. It travels along a sensory nerve fiber and activates a pain receptor. The two basic types of nerve fibers or receptors are labeled A and C. A has the myelin sheath. It's a larger fiber size with fast conduction because of the myelin sheath, and the type of pain is sharp and well localized. C has no myelin sheath, has slow conduction speed, and the type of pain is dull and non-localized. The site where these fibers enter the spinal cord is referred to as the dorsal horn of the spinal cord, which is posterior. And these gates regulate the flow of sensory impulses. Both the opening and closing of these gates has to do with these A and C fibers. The closing of the gate seems to have to do with the A fibers, so pain is not perceived, and the opening of the gate has to do with C fibers. So A is the one we can control with massage, non-pharmacological ways to do that. And then let's look at our neurotransmitters, enkephalins and endorphins. They're produced by the body to fight pain, and they're called our natural or normal painkillers. They're capable of binding with opioid receptors and inhibiting the transmission of pain impulses by closing the gate. So again, these are referred to as our endogenous opioids, meaning we make them inside the body, and they help us. They help us keep pain at bay. Okay. Malignancies, main consideration is with a patient is comfort and not to prevent addiction. At this point, does it really matter? How much longer are they going to be here? This means aggressive treatment with increasing scheduled doses of opioid analgesics to relieve pain and prevent it from reoccurring. As the disease progresses, the patient may need larger and larger doses and more frequent medication administration using oral, rectal, transdermal, and or parenteral routes. Usually due to increasing pathology, there may be some tolerance. For long-term use, injectable forms of these medications are contraindicated because whenever we have a break in skin integrity, we can cause infection. Also, if the patient is taking long-acting narcotic analgesics, breakthrough pain may be a problem, which we're going to talk about in a little bit. Adverse effects of all opioids is going to be constipation. Respiratory depression is the biggest, and nausea and vomiting. But adverse for long-term use, constipation, our GI tract peristalsis is decreased due to central nervous system depression. We know we're depressing everything, and that's why all the movement in the colon stops. And sometimes the constipation is worse than the pain. So we really have to manage that by starting them immediately with stool softeners and or maybe some type of a mild cathartic like Senna or bulk laxative if they can do it with fiber. Okay. So our goal from our World Health Organization is the patient to be pain-free. There's a 3-step analgesic ladder. Step 1, we're always going to use non-opioids with or without an adjuvant med once the pain is identified because we always want to use the least chemically altering of the brain possible. Step 2, we're going to use our strong opioids with or without the non-opioids or an extra type of medication. And step 3 is indicated for moderate to severe pain where we're definitely going to use the opioids with or without a non-opioid or an adjuvant med. So opioids and agonists, they cause an analgesic response by binding to an opioid pain receptor in the brain. Agonists, what that means is it's going to stop the pain. It's just going to stop it. And so a mild agonist would be codeine, Vicodin, oxycodone. Strong agonists are strong opiates, are morphine, Dilaudid, methadone, Demerol should be in this group. Oh, the Demerol's down here. Meperidine is Demerol. Not recommended for long-term use because over time they say you can only use Demerol for 2 days. After 48 hours, it produces a neurotoxic metabolite called normeperidine, and it can actually cause seizures and cause all kinds of problems. So let's see, levophenol next to the Dilaudid there is similar to morphine for chronic back pain. I think I covered the rest of them. Okay. The opioid receptors, there's 3 of them. They're called mu, kappa, and delta. Mu Kappa is Kappa, and delta. From a excuse me, from a pharmacological perspective, mu receptors are the most important because our opioid analgesics act primarily by activating these receptors. They produce a weak activation on kappa, and they don't interact with the delta at all. So that's just from a pharmacological perspective. And just as a side note, hydrocodone, which is a mild agonist, Vicodin, is the most prescribed drug in the United States. And they're saying now over 131 million prescriptions were written in the last several years, in the last couple of years. Far more than 70 million prescriptions for thyroid and 94 million for Simvastatin, which is, and codeine. Simvastatin is for high cholesterol. And I think that concludes our first video for opioid medications.